Good morning. Our next class is Alzheimer's disease. Here we will mainly see the pharmacotherapeutic aspects of the Alzheimer's disease. We will be mainly seeing the most commonly used drugs in the management of Alzheimer's disease, and we will initially we will discuss a few points about the pathophysiology as well as the clinical features of this Alzheimer's disease. So, what do you mean by this Alzheimer's disease? It's a slowly progressive neurodegenerative disease, and there is impairment of memory, and eventually by disturbances in reasoning, planning, language, and perception, it ultimately may lead to a complete vegetative state. That means it affects all the cognitive functions of a human being. This condition was first described by a German psychiatrist, Alois Alzheimer, in 1906. That's why this disease is named Alzheimer's disease. So, now we are moving on to the etiological factors associated with the development of this Alzheimer's disease. So, advancing age, positive family history, and genetic factors and certain environmental factors are also said to be associated with the development of this Alzheimer's disease. And certain comorbid illnesses like presence of diabetes mellitus, hypertension, hypercholesterolemia, they all said to increases the risk of this Alzheimer's disease. And also there is deficiency of folic acid as well as vitamin B12, and low dietary intake of fruits, vegetables, and very low amount of exercise is also a potential risk factor for the development of Alzheimer's disease. Now let's see the role of genetic factors in the development of Alzheimer's disease. So the most common genetic factors associated are mutations in APP gene as well as presenilin 1 and 2 gene. So these mutations, the mutation in the APP gene as well as presenilin 1 and 2 gene, which leads to increased production of amyloid precursor proteins. So these amyloid precursor protein synthesis is increased and they are getting accumulated in the CNS, and these amyloid precursor proteins are being acted upon by certain enzymes like beta secretases as well as gamma secretases. So these precursor proteins getting proteolytically breakdown and leads to the formation of certain amyloid proteins like A beta 40 as well as A beta 42, and these amyloid proteins accumulated and aggregated, which leads to the formation of amyloid plaques. The accumulation of amyloid plaques is one of the most characteristic pathological hallmark in the Alzheimer's disease patients. And also there is certain tau proteins. Tau proteins means it's a microtubule associated protein. Its synthesis is also increases and it's also accumulated. And these amyloid plaques which are accumulated, which leads to nerve inflammation, oxidative changes in the nerve cells, and ultimately lead to neuronal death. These tau proteins accumulated intracellularly, which leads to the formation of neurofibrillary tangles. This also leads to neuronal death. So there will be impairment in the neuronal transmission. This picture shows the accumulation of these tau proteins as well as amyloid plaques in the CNS. Here intracellularly, the accumulated tau proteins leads to the formation of neurofibrillary tangles, and as well as the extracellular accumulation of amyloid plaques, which ultimately leads to destruction as well as death of the nerve cell, and there will be impairment of the intercellular connections of this neuron. So the impairment in the connection, which ultimately leads to impairment in the impulse transmission, which later impairs the different functions of the CNS. Moving on to the clinical features of this Alzheimer's disease. In the earlier stages, patient may have mild forgetfulness, mainly about names as well as recent events, and they feel difficulty in processing about the new information, learning new things, and following certain conversations, and also they have problems with the orientation in date and time. And in the middle stages of this disease, the memory loss is still persisting, and the people usually in this stage usually requires help in bathing, using toilet as well as in dressing, and they feel forgetfulness about their personal history, and they face difficulty in recognizing friends as well as family members. In the later stages, the patients usually lose their ability to remember as well as communicate. There will be severe disorientation about time, place, and person. Usually become bedridden, and there is usually associated inability to swallow the food, so which leads to malnutrition, and they usually become unresponsive to various stimulus, and usually this stage ends in death due to complication of several infections. These patients may experience certain behavioral symptoms also, just like irritability, agitation, delusional thinking, anxiety and depression, hallucinations, insomnia, and sometimes generalized seizures. Thus, they require the treatment for uh, these behavioral symptoms also. Now, let's see the diagnosis. Most of the times, the clinicians require only the clinical history. By getting the clinical history itself, they can derive the diagnosis of Alzheimer's disease, and in very uh, few cases only they need additional support from the investigations, just like memory test or problem solving test, and imaging of the brain, just like MRI or PET scan. Then few points about the neurochemical features of this Alzheimer's disease. The most striking neurochemical disturbance is the acetylcholine deficiency. It results from the atrophy and degeneration of the subcortical cholinergic neurons. So the restoration of acetylcholine transmission is the mainstay in the management of Alzheimer's disease. And there may be certain other neurotransmitters are also playing certain roles in the development of Alzheimer's disease. For example, glutamate or 5-hydroxytryptamine or other neuropeptides. But we don't have all drugs to modulate all these receptors. So we mainly focusing on the acetylcholine system, and we have some or one or few drugs for modulating other neurotransmitters also. Moving on to the treatment part of Alzheimer's disease. First, the drugs useful for the management of cognitive symptoms. So we have two major groups like cholinesterase inhibitors as well as glutamate receptor antagonist. So the cholinesterase inhibitors are like tacrin, rivastigmine, donepezil, and galantamine, and we have memantine as an NMDA glutamate receptor antagonist. NMDA is one of the glutamate receptor. So first we will see the cholinergic activators or cholinesterase inhibitors. As we have already said, the cholinergic system is the most damaged system in Alzheimer's disease. Our role is to restore the cholinergic transmission. So for the purpose of restoration of cholinergic system, we use uh, cholinesterase inhibitors. Initially, we tried the conventional agents like haricolin, bethanchol, oxytrimorin, and as well as physostigmine. But these agents produced severe peripheral side effects, so their use is discontinued. Nowadays, we are using only certain cerebroselective agents like tacrin, rivastigmine, and donepezil and galantamine. So the first agent is tacrin. It was the first centrally acting anticholinesterase developed for the purpose of treatment in Alzheimer's disease. This drug inhibits both the acetylcholinesterase as well as the butyrylcholinesterase. It's a non-competitive inhibitor of this enzyme, and it was tried for the mild to moderate cases of Alzheimer's disease, but it produces severe hepatotoxicity, and because of its hepatotoxic potential, its use is being restricted, and this drug is metabolized by the cytochrome enzymes. The second drug is rivastigmine. It's a carbamate derivative of physostigmine. Rivastigmine also inhibits both acetylcholinesterase as well as butyrylcholinesterase. Being highly lipid soluble, it easily crosses the blood-brain barrier, and it's a non-competitive inhibitor of acetylcholinesterase. It's mainly administered for mild to moderate cases of Alzheimer's disease. And this rivastigmine is metabolized by esterase enzymes, We can administer this rivastigmine through both oral routes as well as through transdermal routes. The next agent is galantamine. It's a natural alkaloid with selective action on the cerebral acetylcholinesterase. It's a competitive inhibitor of the acetylcholinesterase enzyme. It's indicated for mild to moderate cases and it's metabolized by the cytochrome enzymes, especially P2D6 as well as P3A4. And we can use this drug orally through different preparations like immediate release preparation or extended release preparation. The next cerebroselective acetylcholinesterase inhibitor is donepezil. It's also a non-competitive inhibitor and it's indicated for mild to severe cases of Alzheimer's disease. And just like the other drugs, this drug is also metabolized by cytochrome enzymes, mainly P2D6 as well as P3A4, and we use this drug as a single dose administered in night times. This table shows the important features of all the four drugs which we have discussed earlier, and all the four drugs inhibits the acetylcholinesterase enzyme, and only the galantamine acts in a competitive manner. All the other three they act in non-competitive manner, and the donepezil is the only agent which preferred for severe cases, and all the rest of the three preferred for mild to moderate cases. And the major side effects associated with its uses include gastrointestinal adverse effects, muscle pain, and sometimes weird dreams. And this tracrin produces severe hepatotoxicity, and because of this severe hepatotoxicity, its uses is restricted. Now the next group is NMDA receptor antagonist. Among this, we have our agent is memantine. It's a non-competitive antagonist of the NMDA type of glutamate receptor, and it thus decreases the glutamate transmission. Actually, this glutamate has an important role in maintaining the memory and learning, but excess glutamate leads to disruption of nerve cell communication or nerve cell death. That means it produces an excitotoxicity. So this, by using this NMDA receptor blocker memantine, we can reduce the excess glutamate activity, and this agent is usually used along with anticholinesterase drug to produce a added benefit. This memantine is preferred for moderate to severe cases of Alzheimer's disease, and it's not preferred in mild cases. And so, any patient with Alzheimer's disease is not started on memantine initially. Initially, the patients will be started with acetylcholinesterase inhibitors, and later only this memantine is added. And this drug is excreted mainly through the kidneys. So, the dose reduction is required in cases of renal impairment, and its use is associated with certain adverse effects like diarrhea, nausea, headache, abdominal cramps, bradycardia, and altered sleep with bad dreams. Now we will see few other drugs which are said to be useful in patients with Alzheimer's disease, and most of these drugs are either under trial or they are not using that much commonly. So the first agent is an acetyl L-carnitine. It's a structural analog of acetylcholine. It's in clinical trial. And the second drug is a cerebral vasodilator, and it's a dihydroergotamine. It increases the cerebral blood flow. We can administer this drug orally as well as through the sublingual routes. And the third agent is nootropic drug known as piracetam or aniracetam, and it's believed to be enhances the glutamate release. And the fourth drug is citicoline. It also improves the cerebral function by increasing the cerebral blood flow, and administered through the oral route. And next we have ginkgo biloba. It's an extract from the Chinese plant, and it contains ginkgoflavin glycosides. It's a platelet activating factor antagonist, and it prevents the cerebrovascular insufficiency. And the next drug is pyretinol. It acts by increasing the blood flow to the brain as well as it increases the cerebral metabolism. So by this action it improves the cerebral function. And the next agent is pyribedyl. It's a dopaminergic agonist, and thus it improves the memory as well as concentration. And now we have certain other drugs which are in different phases of clinical trial for testing their effectiveness in Alzheimer's disease. The first one is an anti-amyloid vaccine against amyloid proteins like beta 42, and the next is a bapineuzumab. It's an anti-amyloid monoclonal antibody. And the third one is beta and gamma secretase inhibitors. That means that's enzyme inhibitors that decreases the production of amyloid beta, and a metal chelating agent cleoquinol. So this glycanol they binds to zinc and copper. Amyloid proteins they binds to the zinc and copper. So by removing these metals from the CNS, we can reduces the deposition of this amyloid protein in the CNS. And the next agent is nerve growth factors for the loss of cholinergic nerves. And next is the management of behavioral symptoms in Alzheimer's disease. So the behavioral symptoms include agitation, anxiety, depression, and seizures. So we need to have a different groups of drugs for the management of all those symptoms. So we can use benzodiazepines like diazepam and lorazepam, and in low doses of atypical antipsychotics like risperidone, quetiapine, olanzapine, and lithium like mood stabilizers, and phenytoin or carbamazepine for generalized seizures, and tricyclic antidepressants as well as selective serotonin reuptake inhibitors. And that's all about the pharmacotherapy of Alzheimer's disease. And we have different classes of drugs for the management of several symptoms in Alzheimer's disease. Like for the cognitive symptom improvement, we use drugs like cerebroselective acetylcholinesterase inhibitors like tacrin, rivastigmine, donepezil, galantamine, and memantine as an NMDA receptor antagonist. And for the management of behavioral symptoms, we use different drugs like benzodiazepines, selective serotonin reuptake inhibitors, tricyclic antidepressants, anti-epileptics, and mood stabilizers like lithium. But even after the use of these vast number of drugs, we can't assure 100% cure rate in Alzheimer's disease. So we are still in the path of developing several newer drugs for the management of or for the improvement of symptoms in Alzheimer's disease. And thank you.